Hi, my name is Meredith Caldwell and this is Dr. Sally Ireland. Today we are going to perform our anesthesia video on our patient here. This is Edgar. He is our 6-month-old male domestic medium-haired feline. So what we're going to start with is his physical exam. So we'll go ahead and just take a look at him. Hi, buddy. I know. Check the ears. Gonna listen to you. Oh my God. It's thumping. Good boy. Good boy. He's half purring, half vibrating. Alright. Baby belly. As you purr. For hurting. And then we are going to make sure that we have both of our testicles. I hope you do. And yes, they are both there. So on my exam, I didn't see anything significant. Any significant findings? His lungs are clear. He's got a good heart rate. He's got good color. No hernia, and both testicles present. All right, so we're okay with proceeding with our neuter. We did do blood work on him this morning as well, and everything came back with the normal lumens. There was nothing out of place on that. So for the procedure, we are going to start with our anesthetic protocol. So his pre-medication for today is going to be a combination of butorphanol and acepromazine, and we'll give that to him intramuscularly. That does have some pain properties to it, so that will help with the pain throughout the surgery. We'll be inducing him with propofol, and then he will be on isoflurane for maintenance, and he'll be on a fluid rate of 15 mLs per hour. And then for post-operatively, we're going to be sending home buprenorphine, which will help with any pain afterwards. And then we went ahead and did his calculations, and Dr. Ireland and I both confirmed that all of our calculations for our drugs and our fluid rate, the percent oxygen, everything like that was good. So he is ready for surgery. So now we're going to go ahead and set up our OR for surgery. First thing we're going to do is we're going to turn on our oxygen. We want to make sure you have an adequate amount of oxygen. The little gauges here will tell you if not. When it gets down to the red, obviously you need to refill it. This is our anesthesia machine here. We're going to go ahead and put everything together. So we have our bag here. It's our 1-liter bag, which is the proper size for our patient today. Then we have our pediatric tubing. We're going to attach that as well. Alright, and once we have this attached, we want to make sure too that our anesthetic level, if you can see, is adequate. It is in the middle, so it is adequate. If it goes down below this little mark right here, we will need to refill it. So we have adequate anesthesia. We have adequate oxygen. And now we're going to go ahead and pressure check our machine. So for that, we have to make sure that our pop-off is all the way down. All the way down. Alright, then we're going to put our thumb over the end of our tubing. We're going to turn our oxygen on. And then we're going to go ahead and fill the bag. Alright, and then we're going to watch the gauge up in the middle. Once it gets to 20, we want to hit it there. And as long as it holds there for at least 10 seconds, our machine is good. It's just actually going past 20, so our machine is holding very well. And once you're done with that, you release the pressure by opening it back off the pop-off valve. And our machine will not leak. Okay, now we're going to check our scavenging system and our soda lime canisters just to make sure that everything is attached properly and that nothing needs to be changed. Here is our monitoring equipment that we're going to be using today. This is the screen which will show all of our vital signs. This is our pulse ox that will give us our percent oxygen. We have our ECG leads here that'll give us a nice reading. We have a rectal thermometer to maintain our patient's temperature. And we have a blood pressure monitor that does come with several different size cuffs that we will fit properly to our patient. We'll be administering fluids throughout the procedure. We're using lactated ringers. There's a new bag attached to a fluid pump with the correct fluid rate, attached to a power source with a brand new needle that will attach to the line right before administering to our patient. All right, this is our anesthetic monitoring sheet where we'll write down all of our findings. Our setup for catheters, we have 2 different size catheters, a cap, scrub, alcohol, flush, tape, gloves, clippers, and vet wrap. We also have some eye lubricant for our patient. We have a laryngoscope, 2 different size endotracheal tubes, an empty syringe to inflate the endotracheal tube cuff, blue tie to secure the endotracheal tube, the correct pediatric tubing, and reservoir bag for our patient. Now we're going to pre-med our patient with an intramuscular injection. The syringe is placed perpendicular to our patient. We inject, pull back on the hub to ensure no blood, inject the medication, and then we'll go ahead and cover for about 60 seconds. All right, now we're going to move on to the catheter placement for our patient. We are using the left femoral vein of our patient. You want to try to maintain an aseptic technique if you can. It can be very difficult to do. So I go ahead and I have my gloves on. And then we start by clipping the hair of our patient. Most patients, you're going to have to clip the hair in order to see the vein. Even very short-haired dogs, you have to do that. And once the hair has been clipped and removed, we'll go ahead and start scrubbing. We're going to do an alternating pattern of chlorhexidine and then alcohol, and we'll go back and forth for at least 3 swipes of each. I believe here I do several more than that, but you want to do chlorhexidine, alcohol, chlorhexidine, alcohol, chlorhexidine, alcohol, or whatever other pattern that your hospital uses. Alright, you want to be careful when you're scrubbing too, not to make it too wet because it can also make it very slippery and very hard to place your catheter. Alright, so the next thing we'll do is we'll go ahead and pull out our catheters and our caps, remembering not to open anything until we have decided we're going to use it, just to maintain that aseptic technique and make sure that the catheter and the caps don't touch anything or get hair or anything that could introduce bacteria into our patient on them. Some people will flush the catheters as well. I prefer not to, but you can if you'd like to, and flush the caps as well, but I prefer not to. So here I actually will lay the cap on the towel. It's not an aseptic technique. It should stay on the tray where I have all the other equipment. So don't put the cap down there when you're placing the catheter. It doesn't help with the aseptic technique because the towel technically is not clean. It's just what we're using to lay our patient on. So now that we're ready to place our catheter, we'll make sure we have the bevel up on the catheter, and we'll go ahead and place our catheter in the vein. Cat veins can be very difficult. Sometimes they're very superficial, almost like landing a plane. So we're looking for a flash of blood in the hub of our catheter, and once we get that flash, which you can see, we'll go ahead and advance the catheter just a little bit more. And as long as everything is continuing to flow, we'll go ahead and push the catheter off. And you can see the blood there, so our catheter is in place. Our assistant is going to go ahead and grab right below the catheter, and we're going to go ahead and attach our cap. With our left hand, we're going to use our thumb and hold onto the foot and secure the catheter in place. We don't want it to fall out because at this point it is in. I do remove my gloves at this point just because it's easier to tape and not tape the catheter in. But you shouldn't. You should leave your gloves on. So we'll make our butterfly wings with our thin piece of tape, and then we'll wrap around. Securing the catheter in place, we want to make sure that we tape it snug but not too tight. If we do tape it too tight, we can cause some swelling of the paw, which can be uncomfortable to the patient. All right, then we'll take a thicker notched piece of tape, we'll slide it right under the catheter, and then we'll wrap it around like we did before, just adding more security of our catheter. Since our patient obviously here is very wiggly, we want to make sure it's as secure as possible. And then we'll take one more thin piece, which I will break in half, and then we'll do a crisscross X around the port and the catheter attachment to make sure that it will not go anywhere if our patient decides to wiggle or move or anything like that. So once that is in place, we'll place some vet wrap on the outside, and we'll notch it and slide it under, ensuring that we'll just add a little extra security to our catheter. Once again, making sure it's secure but not too tight. And like I said before, if we do it too tight, we can have some swelling of the limb and the paw, which can be very uncomfortable and irritating to our patient. Now that the catheter has been in place, we're going to check its patency. So we'll pull back on the syringe, and then we'll go ahead and inject the flush, which is going through nicely. All right, now we're at the induction portion of the surgery or procedure for today. So don't do what I did first. Start by checking the patency of the catheter. Always want to do that before we inject anything, just because some medications we inject can cause, tissue sloughing and different things like that if they're perivascular or anything like that. So now that we've checked the patency of the catheter, we're going to go ahead and administer our induction agent here, which is propofol. So we'll start with 1/3 of the dosing, and then we'll slowly give the rest of it over the next couple of minutes. We have to remember too that we don't want to give the propofol too fast because it does have some adverse effects. So hopefully as we administer our induction agent, our patient does start to get sleepy and starts to lose consciousness, because our next step will be to intubate our patient, and we are not going to be able to do that if he is awake. So once we finish administering all of our induction agent, we will flush the catheter once again. There are several medications that if you do propofol and then a medication, it can form a solid. So we want to make sure that we flush that through the vein, and that if we have to administer anything else, we can safely. So intubation is our next part. We'll have the assistant hold the head up, and with a laryngoscope, we'll be looking down his throat. We'll go ahead and slide the tube in, remove the laryngoscope, and then we'll take the blue tie and secure it to our patient. And then we'll check to make sure that the tube is in correct placement. We'll go ahead and give a couple squeezes on his chest with our head down by the tube, and we'll feel some air if it's placed correctly, and it is. Now we'll lay our patient down in lateral recumbency, and we'll go ahead and get him attached to the anesthetic machine. We will inflate our cuff on our endotracheal tube, and then we'll turn on the anesthetic gas and our oxygen so that we can go ahead and get our patient at a surgical plane so that he'll be comfortable throughout the procedure. We're going to lubricate his eyes as well. Since they cannot blink during surgery, we want to make sure that their eyes do not dry out. It's very uncomfortable for them. So once we do that, we'll go ahead and start hooking up all of our monitoring equipment that we have for our patient, our pulse ox, our ECG leads, our thermometer, our blood pressure, all that stuff, which does take a couple of minutes to do. And we need to remember too, while we are setting up our patient with our monitors and all the leads and stuff like that, we still need to make sure our patient is alive and well. So we need to, with our eyes and everything, make sure that we still are breathing and that we have a good heart rate. Once we get everything checked, we'll check reflexes, we'll check jaw tone, all that good stuff. So our ECG leads are hooked up to the patient. Our pulse ox is going to go on the tongue. We'll have the rectal thermometer placed. And unfortunately, our blood pressure machine does not work right now. It actually won't read, so we're not going to attach that one to our patient. But normally you would want the blood pressure cuff on one of the rear legs or tail, depending on what kind of procedure you're doing. Since we're doing a neuter right now, it's not really feasible to do a blood pressure cuff on the tail. So now that he's hooked up to the leads, I'm going to go ahead and take out my stethoscope and check his heart rate. We're going to get his fluid rate going and attached. And then we're going to go ahead and turn him down just a little bit now that we've got him pretty much on a surgical plane that we want him at. So while Maggie is prepping him for his neuter, I'm going to continue to monitor and watch him, and then I'm going to step out and get myself ready for surgery. So there is our machine. It's on and working. You can see the heart rate, the respirations, the oxygen levels, and you have the good ECG reading. Our fluids are flowing. And our patient is almost ready for neuter. All right, so normally your attire for the surgical suite would be a little different than what I have on right now. You want to make sure that you have on clean scrubs, an overcoat, or some sort of sterile gown needed. Gloves would be needed, a surgical mask, a surgical cap, and booties if you have them. Our hospital has everything besides the booties, so you just want to ensure that you have clean shoes when you go in there. This is supposed to be a pretty sterile environment for surgical procedures, so we just want to ensure that we maintain that sterile environment for the benefit of our patient. All right, so pretty much the gist throughout the entire surgery is going to be about every 5 minutes. We'll check heart rate, we'll check respiration rates, we'll check for reflexes, jaw tone, all sorts of stuff just to make sure that our patient is maintaining a safe level and that he's not sliding into a too deep of a surgical anesthetic plane. We'll check the color of the mucous membranes. We'll check the CRT, all that good stuff just to make sure that our patient is maintaining well and that everything is going safely throughout the procedure. All right, so periodically we'll pan to the different machines that we have so that you can see that they are running and working. We do actually have 2 surgical suites, so you can see the pass-through on the window. Now we're just trying to play ring around the doctor to find good placement for our videographer. All right, so now we are starting our neuter, and everything is going okay just for a little bit, and then you actually, here in just a second, we'll kind of see him start to pull with his foot. So what I'm going to do is I'm going to go ahead and adjust his anesthetic gas level. We're going to go ahead and turn him up from the 2% that we had him on up until 4. We'll leave him there for just a couple minutes. We'll stop the actual procedure that we're doing and let him reach that surgical plane that we want him at for his anesthetic level. So when she started to make the first incision for the testicle, his heart rate increased, his respiratory rate increased. You can see that his back foot, he did have some reflexes, so we just want to make sure that our patient is not feeling anything throughout the procedure. So we turned him up just a little bit, but we're going to go ahead and now that we've got him back down to a level of comfort, we're going to go ahead and turn him back down a little bit, and then we'll slowly wean him down once we become closer to the end of our surgical procedure. So while we're monitoring our patient, while we're checking the oxygen levels, the anesthetic levels, while we're checking our patient, our machines, everything, we want to make sure that we're keeping a good communication going with our doctor. Anything that seems abnormal or out of the ordinary or that we have concerns with, we definitely need to address to our doctor immediately, so that if there is any steps that we need to take, we can do them quickly and efficiently for the benefit of our patient. We don't want to wait until it's too late and then have something terrible happen to our patient. So good communication with your doctor is in utmost importance while you're in the surgical suite. You should be able to anticipate your doctor and your doctor's moves. You should be able to know what they're going to need, what they want, what levels of oxygen and stuff that they want them on. You want to be in total sync with your doctor. This is not only an added benefit to your doctor, but it's a benefit to you and your patient. So, throughout the procedure, you'll see me checking reflexes, like I said, mucous membrane, CRT, respiratory rate, heart rate, making sure that our fluids are running properly, making sure that our machine is running properly, but at the same time, remembering that even though we do have the anesthetic monitoring machines with the leads and everything like that, the best monitor is always the technician. We need, to be diligent and the eyes and the ears, for the doctors while they're in there. The machines are wonderful and they work really well. But like I mentioned before, our blood pressure cuff actually doesn't register very well. So we have to be the ones that know how to do it, and we have to be the ones that know how to check all the needed vitals and everything for the patient to ensure a smooth transition from start to finish of any surgical procedure. So you'll see that I do have a watch on. There's also a clock above my head. We want one or the other in the room, if not both. This will help you when you're counting respiration rates and heart rates. A lot of times you'll have technicians they'll count for 15 seconds and multiply by 4 to get their heart rate or respiration rate. I have some technicians that count to 10 and multiply it by 6. You can count the full minute just to give you a good idea of where you're at on a normal scale range for heart rate, respiration rate, all that good stuff. So in the next little bit, since we're coming close to being done with the surgery, you will notice that I will start turning down the anesthetic gas levels so that our patient will have a smooth transition as they wake up. Once we're almost done, we don't need to keep them as high as we normally would. So what I do is that every so often, every about 5 minutes or so, depending on how fast the procedure is done, I will go ahead and turn the anesthetic gas down about 0.5% at a time. Never, never, never turning them completely off until the doctor is completely done. Sometimes complications can occur or something else can come up to where the doctor needs to make another incision or add another suture or something, and we do not need our patient waking up and feeling any effects of the procedure if at all possible. So we're still turning him down gradually. until we get completely done with the procedure. And then once we get completely done with the procedure, we're going to go ahead and give him a perioperative antibiotic. He is going to get cefazolin. I also wanted him microchipped, so I will do that while he's asleep as well, just because it is a rather large needle and it's very uncomfortable. So if he doesn't have to feel it, I would prefer that. So now that Dr. Ireland is all done, we have turned the anesthetic gas completely off, and he is only breathing oxygen at the moment. And we'll let him continue to breathe oxygen probably for about another 5 minutes or so. This will help to circulate out all of the anesthetic gas that he has been inhaling over the past 10-15 minutes. And while we're waiting for him to wake up, I normally take this time to go ahead and unhook the leads, the pulse ox. I am keeping his fluids running. We'll go ahead and deflate his cuff. We'll go ahead and untie the blue tie, which was actually securing the endotracheal tube in place. And then from here, it's kind of a waiting game just to see how quickly our patient wakes up. A good anesthetician will have their patient up pretty quickly after surgery. We want them to go down smoothly and wake up smoothly. So even though he's not on the anesthetic gas anymore, and I do have the leads off of him for the monitoring equipment, I still have to monitor him. I still need to check his respiration rates. I still need to check his heart rates. I will check mucous membrane, CRT, reflexes, jaw tone, stuff like that. That'll give me a good idea of when he is going to wake up. We want it to be smooth, and we need to be 100% prepared, because sometimes they will pop up very quickly and we don't want them biting the endotracheal tube, because if they do, they can end up swallowing it, which would be just horrible, and it's just something that needs to be avoided at all costs. So right now I'm communicating with Dr. Ireland about what's going on with her patient, making sure she knows heart rate, respiration rate. She's great. She always checks in periodically to see how our patient is going and what's going on, and if she wants any changes. Like I said, communication is key. All right. So now that he's been on oxygen only for several minutes, we're going to go ahead and take him off, and now he's just going to breathe room air, which will have about 21% oxygen. We'll leave him in lateral recumbency, and we'll just wait. It is up to him at this point how quickly he wants to wake up. But then again, it's the same thing. Even though he's not on oxygen or anesthetic gas, we want to monitor him. I have my hand right now on his chest, feeling his pulse. We're checking his reflexes, his mucous membranes, his jaw tone, all that stuff. Just because they're not on anesthetic gas does not mean that something could change or go south as they're waking up. So just remember to keep on monitoring until your patient is completely awake. And even after that, you still want to monitor the patient periodically until they're to a stable point of sitting up and moving around and everything. So you can see his respirations right there, counting the respirations, counting the heart rate, all that stuff. You are the eyes and the ears for this patient here. Their lives are in our hands, so we have to take it very seriously and monitor closely until our patient wakes up. He actually does take a little while to wake up. So you'll see me checking periodically. You'll see Dr. Ireland come in periodically just to check to see how he's doing. So while he's waking up, we do have one of the other assistants preparing his cage for recovery. What we'll do is we'll go ahead and place some nice dry, warm towels in there. We will get some thermal support for him. At our clinic, we have heating discs, and then we have some rice socks. We don't use anything like a heating pad because they can cause thermal burns. I've actually seen them, so we don't do those. So we'll have that ready for him. So as soon as he is awake, we'll transfer him to recovery where we'll get him on the thermal support and get him back to his normal self. So while we're waiting for him to wake up, you can do little things, which you'll see me do in a little bit, to kind of stimulate him. You can kind of rub on him and pat on his chest and just kind of scratch around just to kind of stimulate him, to kind of get him to wake up. And then before we pull his endotracheal tube, we want him to have at least 3 good swallows. Before we pull the tube, we want to make sure that that reflex has come back to him and that he can sit up if need be. And you can see too that he is still attached to his fluids. We're going to keep him attached to the fluids until he's almost awake. A lot of times after surgery, we will keep them on fluids. But since this was such a very short procedure, just a neuter for him, we're going to go ahead and just detach the fluids once we're done. The catheter placement for any surgery is very, very beneficial with the direct venous access for fluids, for induction agents, for emergency drugs. So definitely good to have that there. So we're still waiting. He's just taking his time. And some patients do that. Some patients, as soon as they're off anesthetic gas, they'll pop right back up. But others will take a little bit longer, which is fine. We just want to make sure, like I said before, to continue to monitor him, heart rate, respiration rate, color, reflexes, stuff like that. Kind of try to stimulate him a little bit to get the process moving along. We don't want to rush him, but at the same time, we don't want to keep him unconscious for too long because his body temperature will drop, things like that. So we want to get him awake so we can get him warm and get him back to his normal state. All right. So Dr. Ireland's come back in and we're still talking about how everything is going with him. Trying to get him to kind of wake up, if there's anything extra that we can do. All right. Still waiting. Just seeing if he's in there. His eyes are actually still rolled back and his third eyelid is still rolled up. So he is still feeling the effects of his anesthesia. So it still may be a few minutes. So we're checking his reflexes right now to see if he's able to swallow by pulling on his tongue, which he's not. So it's, like I said, it's kind of a waiting game. Some patients will wake up very quickly and others will take their time. We'll go ahead and see if we can stimulate him a little bit by rubbing and loving on him, just to see if we can get things moving. we're still waiting, so he's just taking his time waking up. But like I said, we will continue to monitor him to make sure all of his vital signs are good with his reflexes and everything. So we'll just keep watching until he wakes up. Like I said, we want it to be as quick as possible so we can get him back to the recovery area to warm him up and get him back to normal, to his conscious state. All right, he should be waking up here any minute now. And like I said, we want to make sure that he does have the capability to swallow before we do pull our endotracheal tube, and that he is able to stand up sit up as well. That way, if he does vomit or anything like that, he doesn't have the risk of aspirating, which can cause a whole nother issue that we don't want to deal with if we don't have to. Dr. Ireland's still in here too, just, talking about how the patient's doing, and we're trying to stimulate him to help him wake up, pulling on his ears, seeing if he's in there. He is, but he's just taking his time. All right, so checking the heart rate one more time. It should be slowly increasing from when he was under anesthetic gas. Same with respiration rate and everything like that. Everything should be coming up and returning to the normal rate. And then hopefully any second now he will wake up. Now you can start to see his head twitching a little bit. He is starting to come out of the anesthesia nicely. You can actually see that he's able to blink now. He's actually pulling his eyes shut. So he is definitely in there. He's starting to kind of feel the effects of the surgery. You can see him starting to kind of tense up a little bit. He's starting to get closer to waking up.
He's in there. He's almost awake. You can see he's starting to pinch his eyes. There he is. And now that he is sitting up and that he is swallowing, we'll go ahead and remove the endotracheal tube. And now get him back to the recovery area. Okay, so we don't have a crash cart in our hospital. We just have like a crash drawer that has pretty much everything you need. Needles, syringes, blood tubes, catheter, tape, laryngoscope, vet wrap, anything and everything that you would have in a crash cart is pretty much in here. Um, these are the drugs that stay in this drawer. We also would need for a crash cart to have fluids, endotracheal tubes, lines, stuff like that. But they are right here, right next to the crash drawer. There's the extra laryngoscopes here in the anesthesia machine. We don't have a crash cart, so we kind of just have a makeshift drawer that has everything, and then knowing where everything is also is the added benefit. So that's kind of like our crash drawer. This is proof of changing the soda lime and the F-air canisters. We keep track of them on this piece of paper in our surgery suite.
We're all done with surgery, so now we're going to go ahead and clean up our surgery suite. First thing I'm going to do is I'm going to go ahead and turn the oxygen back off. Definitely don't want to leave it running. On the machine over here, you want to make sure that this oxygen level is also all the way down. You can flush the machine if you want to, just to make sure that everything goes back down on the gauges over here. And then make sure that all of our anesthetic gas is off as well. And then with all of our cords and stuff over here, if they do have any blood or debris or any type of tissue or anything on them, you want to wipe them off, normally with Kennel Sol or alcohol. As you can see, they're a big tangled mess. So these didn't get any debris or anything on them, so I'm just going to go ahead and wrap them back up and put them back in their storage compartments. That didn't work very well. Can we cut that out? Oh. Okay, having difficulties here. Well, she said to be natural. Alright. Somebody's gonna walk by any minute. I can feel it. Alright, we want to get everything nice and secured and out of the way. We are going to clean our thermometer though, because that was dirty. I think I'm missing. And obviously we want to turn our machine off as well. Don't want to leave that running. So we'll take a paper towel and some Kennel Sol and we'll just spray a little bit on here. And we'll clean the end of the thermometer that was in our patient. Making sure we remove any feces or anything that might be on the end of it. And then we'll do the same thing. We'll wind it back up and store it. I don't think there's enough cord here. Alright, and then our IV pump, it's already turned off, but we want to make sure that it is turned off and ready for the next use. So after that, we're going to clean the surface here. This does come off, so I do take it off and want to spray the table with Kennel Sol. Let it sit for a minute or two, and then you're going to go ahead and wipe everything off, making sure you get rid of any debris from the table. And we can place this back on top, and we're also going to wipe this off because this is what our patient was on. And it's cleaned up and ready for the next use.
Okay, so now we're going to clean our endotracheal tubes. As you can see, the tube is inflated. You want it inflated, and we're going to go ahead and soak them in Alkanox and hot water. keeping them separate from the other instruments because some of the instruments are sharp and they can poke holes in the tubes, which you don't want because then they won't inflate. And then with warm water, after they've soaked, you'll rinse everything off, making sure that if there was any mucus or saliva or blood, vomit, anything that gets in the tubes, you get them out. And then once you have made sure that everything is clean, you'll sit them out to dry, and then we'll replace them to the racks in the anesthesia rooms, which are right there. This ensures all the water and everything gets out of the tubes before the next use.
We've cleaned up and done everything with the surgery. We're going to go ahead and record our drugs. This is our drug book that we keep everything in. There's little tabs for each of the controlled substances that we have in hospital. So for this, when we're writing it down, we'll write today's date, and then the owner's name, which is me, so I'll write my last name and my first name. And then we write our pet's name, which is Edgar. He is a feline. And then we write our chart number. And then we write how much that we use, which is 2.4 cc's for the buprenorphine that we're sending home. We used it, we didn't waste any of it, and then we have to subtract that from the total here, which would leave us with 50 cc's. And then I'll write my initials, and then the doctor, that's me. There you go.
Okay. Now it's been several hours since surgery has happened, and we're going to do our post-op exam on our patient. We'll go ahead and take his temperature, which he probably is not going to like. We want to make sure that our patient is not too cold and is not running a fever or anything like that. And then once we have that done, hopefully our patient will continue to cooperate. We'll check his heart rate, we'll check his respiration rate, we'll just give him a good look over, check his incision site just to make sure there's no swelling, bleeding, oozing, anything weird like that. We'll check his pain level as well, just to make sure he's not painful. And then depending on which doctor's in charge, sometimes they will have you feed the patient, go ahead and give the first dose of medication so that the owners don't have to worry about anything at night. But I am the owner of this patient, so we don't have to worry about that. So we'll watch him breathe, we'll do his heart rate, we do his temperature, we're checking him over. He's bright, he's alert, he's responsive. He doesn't seem painful. He actually seems very comfortable. He was actually asleep in the cage before I pulled him out. And then once we have him out too, he still does have his catheter in place. So, First, we're going to give him his first dose of medication. The buprenorphine is absorbed through the mucous membranes very well. So for pain, even though he doesn't seem super painful, we'll go ahead and give him some just to prevent any pain from happening. Like I was saying earlier, he does still have his catheter in place, so we do want to remove that. You never want to send a patient home with a catheter. So with our bandage scissors, we'll go ahead and cut. Make sure you're lifting up as you cut and cut to the side of the catheter. That way you don't actually cut the catheter and leave it in the patient's leg. And then with a little bit of gauze and vet wrap, we'll go ahead and wrap a little bit of a pressure bandage. I always stick my thumb between the first and second layer of vet wrap and ensures it's not too tight, because like I said before, if it's too tight, it'll end up swelling and being painful to our patient. And that's it. Okay, now that we have finished our entire procedure, we want to go ahead and just address some things that were left out in the video. One of the first things was that our patient on our physical exam had no retained baby teeth. A lot of our patients that we see about this age, about 6 months old, they should have lost all their permanent teeth, and sometimes they have not lost them, so we want to extract them while they're under general anesthesia to prevent any problems in the future. And then with our pre-medication and inductions, I did not mention the 5 R's. When administering any type of medication to a patient,
You want to make sure that you have the right patient, the right medication, the right dosing, the right route of administration, and the right time to give the medication. Definitely do not want to give the wrong medication to the wrong patient, or give something to a patient that is contraindicated for a condition that they have. So you always need to check the 5 R's to make sure that we are giving the correct medications to our patients. Okay, prior to us inducing our patient, I did not auscultate the patient. After the patient has been pre-medicated, we do need to double check the vital signs just to make sure that there are no adverse effects occurring from the pre-medication. So you will auscultate the chest, check the respiration rate, check the heart rate, check all the vital signs just to make sure that the patient is still stable and ready for induction. Now, while in surgery, you're supposed to have a clipboard or some type of device that you can put your piece of paper that you're recording all of your vital signs on. You do not see me with one or even recording any of the vital signs while in the surgical suite. I was actually relaying them to the videographer who was recording them for me, but normally you don't have that option. You need to have the clipboard in there, and you need to be the one writing down heart rate, respiration rate, pulse ox, percent oxygen, percent anesthetic gas, all that stuff. And then in the surgical suite, you actually don't see Edgar on any type of warming device. We actually don't have anything for them for surgery. We usually put them down with some dry towels, and then for dentals and longer procedures, we will cover them with a towel or a blanket of some sort. This was a very short procedure, so his temperature didn't drop too low, but it did drop low. If it started to get lower, then we would have added some type of thermal support. And like I mentioned earlier in the video, it would be some sort of support like a heating disc or the rice socks, or what we call happy hands, which are just the gloves filled with warm water. Nothing is going to be directly on the patient. You always want to have some sort of buffer between the thermal support and the patient, just so we don't scald or burn their skin. Alright, our patient here too is on a rebreathing system. Normally for a patient his size, he would be on a non-rebreathing system. Ours unfortunately does not properly work. It actually leaks while we use it. So we do have him on a rebreathing system. That is not accurate, but it was doable for this procedure. Also, I talked about his recovery suite, like what it would look like and where he would be, and it is just a cage that he will be up in our treatment area so that we can monitor him. There'll be dry towels, there will be thermal support if needed, there will be eyes on him monitoring his recovery, making sure there's no vomitus or regurgitation or anything like that. As he goes back from the state of unconsciousness to consciousness and back to his normal state before he goes home. I also did not show my conversation with Dr. Ireland about his post-operative exam. I performed it with my assistant, and I did discuss it with her, but I did not show the conversation that we had. I just discussed what my findings were, his pain score, and all that stuff, and everything was working out great, so she said that he was fine to go ahead and go home that evening with me after work.